The most dangerous diagnosis in the ED isn't always the rare one. Sometimes it's the one we decide on too early. We see a familiar story. We recognize a pattern. We anchor on the obvious answer. Cognitive bias is what happens when our brain's shortcuts start driving the differential. Hi, I'm Dr. McLoughlin, and in this episode of Teach Me Something New in Under 5 Minutes, I'll show you how cognitive bias shows up in real time and how to catch it before it catches you. We've trained to think fast, and in the emergency department, that's essential. But fast thinking comes with a trade-off. We rely on mental shortcuts, aka heuristics. Most of the time they help, but sometimes they mislead us. Let's talk about the clinical reality. You see a few similar cases, you recognize a pattern, and your brain says, I've seen this before, and that's where cognitive bias begins. So what is cognitive bias? Cognitive bias is a predictable series of errors in thinking that affect decision-making. These aren't rare. They're part of how every brain works. The three big ones that you need to know in the emergency department are anchoring, where you lock onto the first impression and struggle to move off it. It's probably just reflex. Premature closure, you stop thinking once you have an answer. Diagnosis made, move on, next patient. And availability bias. Recent or memorable cases dominate your thinking. I saw 3 viral syndromes today. This must be another one. The key idea here is these aren't knowledge gaps. They're thinking traps. So why does this matter? This is where it gets real. Cognitive bias contributes to diagnostic error, missed critical illness, delayed treatment. And in the emergency department, we're high volume, high pressure, constantly switching tasks, which means we are perfectly set up for these errors. The clinical translation, it's not the rare diagnosis you don't know that hurts patients. It's the common one that you misinterpret. Here's the practical part. Think of this as a quick mental reset. Step 1, identify the trigger. Some high-risk moments are you feel very confident very early. The case seems straightforward. Or you're moving fast and feeling rushed. That's your cue. Pause. Step 2, ask one question. What else could this be? Force yourself to generate at least one alternative diagnosis, especially something dangerous. This alone can break anchoring, premature closure. Step 3, recheck the data. Go back to vitals, physical exam, key labs, and imaging, and then ask, is there anything that doesn't fit? If you find a mismatch, this is your warning sign. Step 4, slow down the decision point. Before any disposition, discharging a patient, or closing the chart, take 10 seconds and ask, am I closing this case too early? Here's some real-world emergency department application. A patient comes in with chest pain, young, looks well. Your brain says low risk, but you pause. You ask, what else could this be? You reconsider. Is this a PE, atypical ACS, or a dissection? That moment of pause, that's how you catch these misses. So to wrap it up, I share 3 key takeaways. Cognitive bias is universal. Every clinician has it. It shows up most when you're fast and confident. And one simple pause can prevent major errors. Check in with your ego, your body, and your emotions. That pause is for you too. Great emergency physicians aren't the ones who never make mistakes. They're the ones who recognize when their thinking might be wrong and have a system to correct it.